A very good morning to all those in the United States and a very good evening to all those in India. This is Dr. Lynette Fernandez, and on behalf of the Department of Periodontology, GDC Mumbai, and the Indian Society of Periodontology, Maharashtra Study Group, I welcome you all in the celebration of the 7th ISP MSG Virtual Convention. This is the continued session of the convention held on the 31st of July, which was a grand success. We had an enlightening and impressive webinar by ace speaker Dr. Anirban Chatterjee, sir, who kept the audience enthralled with his vast expertise of knowledge. We also had an overwhelming response and received over 67 scientific paper presentations from all over India, showcasing the vast area of research. Due to the huge participation, they were divided into 10 groups, each named after an eminent personality from the periodontal field. Our heartfelt gratitude and thanks to the judges who did a stupendous task. We will be announcing the category-wise winners at the end of today's session. We have special guest speakers today from the United States. That is Dr. Anita Doshi ma'am and Dr. Adam Saul sir, who would be speaking on the topic Placed but Not Forgotten, Avoiding and Managing Implant Complications. Welcome sir, welcome ma'am. Also, we have in our midst today Dr. Dimple Padavi ma'am, the Dynamic Dean of GDC Mumbai, Dr. Nimfia Pandit ma'am, President, ISP Head Office, our moderator for the session, Dr. Ashwini Padya ma'am, the convener ISP MSG, Dr. Dilip Pol sir, and Dr. Rajesh Gaikwad sir, the HOD of the Periodontology Department, GDC Mumbai. Welcome you all. Let us draw the curtains today and begin the ceremony. So we have with us Dr. Veena Vishwanath, who will be singing the Ganesh Vandana to invoke God's blessing for all of us.
Vakratunda Mahakaya Surya Koti Samaprabha Nirvikhnam Kuru Me Deva Sarvakaryeshu Sarvada.
Thank you, Dr. Veena, for your melodious recital. I now hand over the proceeding to Dr. Dilip Pol sir, the founder member of ISP MSG, ex-professor of GDC Mumbai, ex-editor of GIDA and Dental Dialogue.
Paul sir.
जब आप लोग अभी हमने हार्ड कोड किया ना और देखो लिंक वाला डालते हैं ना.
So I think he's not there in the meeting.
There in the meeting.
Yes.
Is there?
Yes, sir, it's coming.
Yes.
Also?
Hello.
Yes, sir.
Are you listening me?
Yes, sir.
There was a problem with the laptop.
Sir, your video and audio is not proper. Video is not coming.
Yes, sir.
Hello. Hello.
Yes, sir, you're audible now.
Audible, na?
Yes,
Yes,
sir.
sir.
So should I start?
Yes, sir.
Yes.
Sorry, actually there was a disconnection or some problem. So anyway, so at the outset, I wish to welcome our dynamic president, Dr. Nimkia Pandit, who has present here. I wish to welcome her and Dr. H.S. Grover, our SP secretary. He had some other book like program, so he could not, but he has sent his best wishes. Same thing, Dr. Anirban Chatterjee, president-elect, he has sent his best wishes for this program. And Dean also, Dr. Dimple Padavi, she was supposed to join, but she has also some program, other work, so she could not join. So may I welcome our international speaker, Dr. Adam Sal, Dr. Anuja Doshi, and our chairman, Dr. Ashwini Padhe. And more and above, the key person of this particular session is Dr. Rajesh Gaikwad and his entire organizing team, and our entire all the participants and delegates in this particular concluding session. After having a lots of various oral activities in last 15 days, so we are here to have this concluding session, of which may be possible due to the participation of our international speaker, Dr. Adam Salt and Dr. Anuja Doshi, taken his important time and adjusting our time zone of with Indian time. So, and moderated by Dr. Ashwini Pade, I wish to welcome again. And really, because you all are the intelligent people and you are deliberating a very basic topics on the implant. So, friends and the participant in this particular session, may I request you try to understand the keeping the intellectual scientific approach and attitude. All the pre-paper presentation and oralize and the video participants have done presentation very nicely with nice innovative ideas and put forward the best paper presenter awardees will be announced after this session. In advance, I wish to congratulate all the party, all the best paper awardee and those who have got consolation prizes in the video this thing actually the presentation and the best paper presentation. So friends, so this is nothing but अभी तो ये शुरुआत है, अभी तो शुरुआत है, बहुत कुछ और अपने आगे देखना है आप सबको. So people, those who are presented, they have to do lot many things. कुछ तो अभी तो आपको मिला है. तो ISP में आपकी असली उड़ान अभी बाकी है. ISP में अगली असली उड़ान अभी बाकी है. आपके इरादों का इम्तहान अभी बाकी है. अभी तो नापी है मुट्ठी भर जमीन, आगे अभी सहारा ISP का आसमान बाकी है. Thank you very much, friends. All the best and good luck. Thanks a lot.
Thank you so much, Dr. Paul, sir, for such enlightening talk. Thank you so much, sir. Now, I would like to call upon Dr. Rajesh Gaikwad, sir, who is the backbone of this very event and head of Department of Pedontology, Government Dental College and Hospital, Mumbai, to give vote of thanks. Over to you, sir.
Good evening, everyone. I will just request our president, dynamic president, Dr. Nimphia Pandit, madam, to guide us to say a few words on this occasion. Actually, she is the one who encourages for this ISPMHG convention, and she was very keen in various scientific events. Usually, since last pandemic, she had conducted various virtual events in this last 1.5 year in these difficult times. So all the credit goes to Nymphia madam. So I request Nymphia madam to say a few words, madam. Nymphia madam. I think Nymphia madam is not there. Vaibhavi, just check. Madam is there.
She's there, but her audio is not connected actually. So she is not there in the meeting actually.
Okay, okay. Whenever she comes, then we will have.
Yes.
So many thanks to Dr. Anuja and Dr. Adam for accepting our invitation and to as a guest speaker for this event, 7th ISPMHG convention. And I request Vaibhavi, actually vote of thanks I will deliver at the end when I will announce the prizes for this contest, video contest. So Vaibhavi,
Okay, sir. So let us now begin with the today's session, the most awaited session by Dr. Adam Saltz and Dr. Anuja Doshi ma'am. Today we have one of the eminent personalities with us, Dr. Ashwini Padhe ma'am, professor and head of the Department of Periodontology at MGM Dental College and Hospital, as a moderator of this session. She is a postgraduate teacher and guide. She is also a proud member of ITI Switzerland. She is a mentor for the Perioprosto Mastership program under the Genesis of EduHub along with Columbia University. She is also faculty internationally and nationally for SmileCare India, which has a tie-up with Department of Continuing Education, New York University. She has several international as well as national publications to her credit. She has also been appointed on the editorial advisory board of Quintensis Asia Pacific Editorial Journal. She is a keynote speaker and has held the live surgical demonstrations at various national and international forums. With a great amount of pleasure, I would like to welcome Dr. Ashwini Padhe ma'am to this session.
Thank you so much, Vaibhavi. Pleasure to be here. Always a pleasure to be on a platform. And there are some invitations that you just can't say no to. One is when it comes from my alma mater, which is Government Dental College and Hospital. Thank you, Paul sir and Dr. Rajesh Gaikwad for actually extending this invitation to me. Hello, Nymphia ma'am. And I'm really glad to be here. So good morning, UK, and good evening, India. Without much ado, let me go ahead and introduce our esteemed speakers for the day. And I think it's a topic which interests me tremendously, and I'm sure everybody who's attending it is going to take back loads and loads to go back home and think about. So let's start with Dr. Anuja. Anuja, we both share the same alma mater. So people who are from JDC are very close to my heart, always and will always be. Dr. Anuja Doshi received her dental degree from Government Dental College and Hospital, Mumbai, India, and her Masters of Science and Certificate in Periodontics and Moderate Sedation from Ohio State University College of Dentistry. Dr. Doshi has completed ADA's Academic Dental Careers Fellowship Program during her time at the OSU. Upon graduation, she joined the University of New England as a full-time faculty and is currently the Director of Predoctoral Periodontics and the Faculty Advisor for the Periodontology and Implants Club. Dr. Doshi has presented her research at the American Academy of Periodontology AAP meetings and at the IARD and AADR meetings. She's also a published author in the Journal of Periodontology and serves as the peer reviewer for clinical advances in periodontics and the Journal of Dental Education. Dr. Doshi committed to periodontal education was recognized by the AAP in 2019 when she was awarded the prestigious Dr. Walter Cohen Teaching Award, and in 2020 with the Outstanding Teaching and Mentoring in Periodontics Award, an AAP Foundation's Fellowship to Institute for Teaching and Learning, and the 2020 AAP Strawman Scholarship Award. Wow, fantastic. And let's move on to our next speaker for the day, Dr. Adam Sals, who graduated from UT Health Science Center and at San Antonio, where he obtained his Master of Science degree and certificate in periodontics. He received extensive training and certification in IV conscious sedation during his residency. He completed his dental training at the Nova Southeastern University as part of their accelerated dual admission program. While there, he also received a Master of Public Health degree. Dr. Sals has published in several scientific journals on periodontal and peri-implant disease, digitalized implant workflows, and immediate implant placements and loading protocols in the aesthetic zone. He also lectures nationally on these topics. He was the finalist in the 2019 AAP Bylund Orban Memorial Program for his clinical research on immediate implants. He won the 2020 Dr. and Mrs. Gerald M. Kramer Scholar Award for Excellence, presented to the nation's top overall graduating resident for outstanding character, service, leadership, and academic achievements. Dr. Sals was recently appointed as an assistant clinical professor at the University of New England College of Dental Medicine and maintains an active practice in South Portland, Maine. Wow. Guys, I'm excited for this session because both of them have so much to, that they've already accomplished at such a young age. So over to both of you guys. Thank you.
Yeah, thank you for the introduction. It's so exciting to be here.
Thank you so much. Like Dr. Ashwini mentioned, it's like a huge honor for me to come back to my roots, where my dental journey began. So thank you, Dr. Gaikwad and Dr. Polser, for organizing this and having me and having Adam here to present. It's a huge, huge honor for me, and I'm truly excited. So should we go get started?
Yeah, sorry, Dr. Anuja, before you begin, just a humble request to everybody who's a part of this to please switch off your videos and audios so that the streaming is not interfered and it'll be much better. Thank you so much.
All right, I can go ahead and share my screen now. Okay. So what we are talking about today is placed but not forgotten. We really wanted to talk about what happens after you place an implant, or what should you consider when you're treatment implanting dental implants, because as we all know, implants have really taken the spotlight in more of the recent 5-10 years. And but as we are placing more implants, we are seeing more implant complications. And we are still not there yet where we know everything about implants. We still don't know how can we treat implant diseases. And a lot of times we are really just, it's a trial and error method. There's still a lot of ongoing research at this point. So we just wanted to share some of our experiences with implant complications, or how we've tried to avoid an implant complication. So we really hope this is helpful. We've tried to keep it short because, again, there's a whole lot of things to talk about when we are talking about this topic. But we try to condense it in a way where we can only highlight some of the things. So starting with the objectives. So we are going to first start talking about the peri-implant conditions using the new classification. So we'll really get into just the case definitions of different peri-implant conditions. Then we'll talk about some of the risk factors that are associated with different peri-implant conditions. So more to understand how can we prevent peri-implant complications. And then we will go into a little bit of how to avoid and manage if a problem does arise. So it's really all, what we've tried to do is we've tried to blend it all together so that if we show you a risk factor, we will show you a complication and how you can manage that. So again, I hope the sequence helps a little bit. So first, again, going to the case definition. So we'll start with what is health. Until very recently, we didn't have a case definition for periodontal health as well as peri-implant health. So as of 2017, now we have a case definition for it. And I think that's useful because only if you know health, you can know when you have disease. So the first thing to know about health is that whether you're talking about periodontal health or peri-implant health is always characterized by absence of inflammation. So all your signs of inflammation, which are your 5 signs, your rhubarb, dollar, calor, and which I'm missing. So that really comes down to redness, swelling, bleeding. Those are your cardinal signs of inflammation. So if you don't have that, that is really your first sign that, okay, this is potentially health. Suppuration can also be the other thing. So if you have bleeding on probing or suppuration on probing, then that's not health. Now with implants in particular, just like in periodontal diseases, we have a number that we go by, right? Up to 1 to 3 millimeters of probing, we normally consider that as health. And anything above that, we start thinking of disease. But with implants, it doesn't work like that. You can't have a probing number for an implant because you can have a 6 millimeter probing depth and it can still be health. So with implant, it really has to be over time. Like if you see a difference in probing depths over time. So if you don't have that, that's health. And again, absence of any bone loss beyond the initial modeling. Every time you place an implant in the first year of function, you have to expect some bone remodeling, but you shouldn't have anything beyond that. So if you have all of this, then you're health. So the next step is peri-implant mucositis. This really correlates with gingivitis. In a case definition of mucositis, you have signs of inflammation. So you will have your bleeding, maybe redness, maybe even suppuration. But the only difference really is that you still won't have bone loss in a mucositis case. You will still see that your bone level hasn't changed beyond the initial remodeling. So that is your peri-implant mucositis. Now moving to peri-implantitis, this is where it gets harder to treat and manage. This is when, other than having all your signs of inflammation, you also have progressive bone loss. Now, again, the key word here is progressive loss, because you have to always have an initial radiograph to compare to, that where it started. Only then you can really say that, okay, there is progressive bone loss. So ideally for definition of peri-implantitis, you should be able to see subsequent bone loss over time, in addition to all the other signs of inflammation. Now, if you don't have that, if you don't have a previous radiograph, or if you don't have something like from the initial visit or over time, then you can use, oops, I keep forgetting. So then you can use 2 of these criteria. You can have, if you have probing depths that are greater than or equal to 6 millimeters, or if you have bone loss that is greater than 3 or equal to 3 millimeters, apical to the most coronal portion of the implant. So in the event if you don't have your previous data, then you can use this. But again, keep in mind that don't use your probing depths as a indicator of disease, because with implants, you can have a large, like a whole area of probing depths that can still be held. The last part that they added to the, oh, actually, Adam, do you want to talk about this?
Yes, just to briefly touch on, so just like Anuja was alluding to, peri-implant mucositis, if left untreated, can evolve into peri-implantitis. Now, there are distinct differences between this and the odontitis or periodontitis that occurs around teeth. Histologically, we know that there's a much larger inflammatory front, almost 2-fold, with an abundance of neutrophils. And this actually causes a much more rapid and acute breakdown of bone around implants, unlike teeth. So the way we manage peri-implantitis, as you'll see, while there are some commonalities between implant and tooth structure, the implant really doesn't behave like a tooth, and so we can't treat it that way. A lot of times the bacterial profile is similar to what we see around teeth, and so I usually tell patients that the phenomenon they see in their disease state, the same bugs, the same bacteria can recur around their implants. So I think from a functional standpoint, knowing that implants don't behave like teeth, but from a disease standpoint, knowing that the pathogenesis is even sometimes more severe than what we see around teeth is just worth noting.
We'll get into further depths of periodontitis and how that can affect your implant health. And that's also one of the takeaways from today, that just knowing that anyone that has a history of periodontitis is at a higher risk of having peri-implantitis, and we'll go into that in the subsequent slides. So the last part that they have added to the new classification of peri-implant conditions is hard and soft tissue deficiencies. This can be either before the implant placement, so prior to implant placement, or ones that exist after implant placement. So just, I will go into this case in a little bit, but in this picture right here, you can see there is almost no keratinized tissue, which is one of the very common things we are seeing now, that patients who have implants, they might have adequate bone, but they don't have that tissue there. Like if you see here, you probably have a millimeter band of keratinized tissue, but almost here you have none. So that's definitely one of the considerations. The other is hard tissue deficiencies around implants. So especially if you have a history of periodontitis or traumatic tooth extraction, those can often result in a hard tissue deficiency prior to implant placement, which again, management of that becomes the key in having a more predictable long-term outcome for implant placements. So how you go about, again, similar case, this is a patient of mine that had trauma here and lost substantial amount of vertical bone. And we did have to do at least 2 rounds of bone grafting before we could get an implant there. So this could happen, especially we see commonly with traumatic extractions, patients lose their buccal plate, so that can always result in hard and soft tissue deficiencies. After implant placement, we see more of your soft tissue deficiency unless if the implant is completely placed in outside the alveolar housing, and we'll get into some of those cases as well. All right, so avoiding and managing complications. The first thing we wanted to get into, before I get into that, so this is a lighthouse that is very close to where we both live. Portland, or all of the state of Maine, where we are both currently at, it has about, I don't know, Adam, you can correct me, probably like 200, 300 lighthouses. So this is one of the iconic ones, and then we'll show you the other one. And this is one of my favorite lighthouses because it's really pretty and it's like, was right in the sea, so. But what I wanted to get at was that the best way to manage implant complications is to prevent them. So you knowing what are the risks, knowing what all goes into implant planning is really the key here, because we still haven't figured out implant therapies like how we can have predictable outcomes. So the best thing you can do if you're doing implant treatment is knowing how to prevent complications. So having said that, the first thing you need to know is your risk factors. So when I'm teaching students, this is something I use for my students. The Swiss cheese model of error was actually used in the medical field when you have a medical complication. But it works, I mean, it essentially works in any healthcare complication. So what it says is that if anyone knows a Swiss cheese, it's essentially a cheese that has holes in it. That's what we call the Swiss cheese. So every time you have considerations or risk factors, it becomes a barrier with holes in it. So whilst you might try to help reduce the patient's risk, it will still be a barrier with a hole. So you have to think about in a way that your one risk factor is not the only problem. It becomes a series of risk factors that eventually leads to failure. Now, when you're talking about implants, you have a bunch of factors that you have to consider. And when all of these factors line up, or even like few of these line up, it will result in an implant failure, or at least in some sort of implant complication. So what your goal of implant therapy has to be is, how do I minimize these holes? How do I make these holes in my Swiss cheese smaller, or to an extent where I can completely not have them, in the order to prevent an implant failure? So there are a bunch of factors that you have to consider, and Adam here will get into that right now.
Yeah, just like Anuja was first introducing, I think one of the biggest points is that we can not always control for these factors, but as long as we're aware of them and the patient is aware of them, we can set more realistic expectations for both the clinical and aesthetic outcomes of treatment. So on a patient level, there are certainly several risk factors of note: poor oral hygiene and a lack of maintenance, history of periodontitis, diabetes, not so much that the patient has diabetes, but a lack of glycemic control. So even if a patient has some state of hyperglycemia, meaning anything greater than normal or 5.4% HbA1c, they're potentially at threefold greater risk for developing implant problems. And then, of course, smoking. Just like periodontitis, cigarette smoking is a known risk factor for peri-implant disease. In terms of site or local anatomy, if you mind just advancing the slide.
Sorry.
No, it's okay. On a site level, we're looking for a lack of keratinized mucosa. So unlike teeth, which we know to have about 2 millimeters or so, some of the evidence in implant placement is controversial about the amount of keratinized mucosa to maintain implants. And we'll see that some important questions need to be asked to your patients of whether or not they can safely and comfortably maintain their implants through treatment. Restorative materials, so different cements, different placement of the provisional or the final contours of the crown can certainly affect the long-term health of the implant. Surgical placement and replacement. So, sometimes when we have to replace implants, not all implants are a success. We know that the survival and success rates over time can significantly decrease. Loading is important. So the timing and the amount of occlusal forces placed on the implant, again, it's not a tooth, and we can't account for it to be one. And poor bone quality. So sometimes too much bone or the density of bone can actually affect the health of the implant. And on a more specific level, when implants are placed in the aesthetic zone, there are even more risk indicators that have to be accounted for. So the patient smile line. So, we know that in these more aesthetic cases, the outcome is that much more critical to achieve. We consider other elements like provisionalization to develop the soft tissue contours, either at time of placement, early on, or as part of delayed healing. Pre-existing bony defects and a thin buccal plate. A majority of patients have a thin buccal plate. So how do we account for that as part of treatment? A thin phenotype. So we now know that a lack of that thick tissue, in addition to a lack of healthy tissue around implants, can certainly cause a greater likeliness for marginal recession. And then, of course, the occlusal scheme. So if the patient has a deep bite, or what other factors may affect the patient's health of their implant in the long term. So on a patient level, one of the first and better known risk factors for peri-implant disease is a history of periodontitis. And according to the 2017 World Workshop, this was really the only proven risk factor for implant disease. Now, an often quoted study is in patients who had been treated for moderate to severe periodontitis. We see here that they have a survival rate of about 90 to 93%. You look immediately at these numbers and you're impressed. Well, okay, I can go ahead and place implants in a previously diseased patient, no problem. But you have to dive deeper, and you first have to understand what survival even means. So survival isn't success. Survival just means that the implant is still in the patient's head. Even if it's by a screw or a thread, that implant survived. So even though it seems high, 90 to 93%, we dive deeper into the same study and we find that a majority, almost 50% of implants in these severe cases required treatment over time. So just like a car requires maintenance, an implant, especially in patients with a history of periodontitis, require that much more. Patients with active disease So anyone with probing depths of 5 millimeters or greater are more receptive to peri-implant complications. And then even those that have residual pocketing of about 6 millimeters or more are more likely to develop this state of disease. So if you forget anything today, it's just remember that once a periodontitis case, always a periodontitis case. And I always tell my patients that the same bugs that affect their teeth can repopulate around an implant. And I think that's just an important line to take away and have discussions with your patient about. So this next patient, Elsa, presented to our clinic, and she was told that her implants are failing. And it's really sad because, again, it comes down to the patient's history. And once we have a proper diagnosis and a history of a patient, we can move through treatment and set up a maintainable plan. Medications really aren't of note here, and no contributing social history either. So when she presented to our clinic, this was actually about 5-10 years ago, she had a panoramic image taken, and the teeth were extracted in about 2010 due to severe periodontitis. So again, these patients, she not only had these teeth extracted, she had immediate implant replacement, and she was treated for a maxillary complete denture hybrid. So she has a lower hybrid opposing a maxillary denture, and she was never set up for a maintenance plan. And again, we know that a history of periodontitis can cause significant problems around implants. Fast forward to 5 years later, she didn't have a maintenance plan, and she actually removed 4 of the 5 implants one night. She took her lower, she thought she was supposed to remove her lower denture, took it out, implants included. I ended up removing one of the last implants, and you'll see in this final image here that we really, in these cases, can make patients dental cripples. It is very difficult now to overcome some of the difficult anatomy here. We see that her tissues are confluent with the floor of the mouth, which make implant replacement that much more challenging. She also, if you just recall from the panoramic view, these very prominent buccal defects. And again, these weren't removed healthfully. She removed them because they were so infected. So just a history of severe periodontitis, that's just, clues you in that much more to safe treatment of patients over time. And the type of periodontitis matters. So what was formerly called aggressive periodontitis, which you'll see in the new workshop as called molar incisor pattern, or a generalized periodontitis in a younger patient perhaps, the risk profile for this is even more severe, 14-fold increased risk for peri-implantitis and 4 to 5 times increased risk for disease. So again, in these patients, if I have a younger patient with pretty pronounced periodontitis, I'll actually go ahead after treatment and place what are called test implants. So if I end up removing teeth as part of treatment, I may only replace one at a time. And I may do so a year or a couple of years afterward, put him or her through a maintenance period to really just make sure they're compliant with hygiene, that they're compliant with maintenance, because you're only setting yourself up for failure. And then when things fail, the patient doesn't challenge themselves, they always challenge you, because they can't be the problem, you're the problem. So again, having these conversations with them is what's also so important. As we learn some of these risk factors, these are things that I talk to my patient about even before I get into the surgical phase.
And just to add to this, like it's not uncommon where we actually see patients that have had implants maybe at a different office. It's not uncommon where we see the patients because they get referred to the periodontist every time there is peri-implantitis. And then we will look at the oral hygiene and it's so poor. They have plaque everywhere and there's subgingival calculus. And that's when it gets frustrating that this could have been prevented. We could have educated this patient could have been on a maintenance recall, and we could have prevented this. So again, make sure if you're placing implants, you're first making sure patient is in periodontal health. And something else I tell students is that when you're getting a knee joint replaced, so say when you're getting any joints in the body replaced, the first thing the orthopedic surgeon wants is a dental clearance, because they don't want disease in your mouth because it can affect your joint. So imagine when you're placing an implant in the mouth, that is not just systemic disease, but you're also putting it literally in the diseased mouth. So if you want to replace a knee joint, which is so far away from your mouth without getting a dental clearance, you really shouldn't be placing implants unless you have a dental clearance within the mouth, right? Great. One.
And I think Anuja brings up a great point. It's so important for the patients to understand what you're doing. And so you'll notice that as her and I explain a lot of these higher level topics, we're really breaking them down with different metaphors and analogies. So these are conversations that we actually have with our patients, because again, we're not necessarily receiving implants in a clean slate to begin with. You know, as specialists in treating peri-implant disease, we often find, you know, a number of challenges that we're now up against and now inherited. So from a maintenance standpoint, this diagram nicely depicts patient and patient level responsibilities for implant maintenance. The green represents the daily oral hygiene of the patient, which should be reviewed by the surgeon and the restorative dentist during healing and after the implant crown is restored. The blue represents their maintenance visits with us. And so we can tailor or individualize this. So a patient who doesn't have a history of periodontitis, we may be seeing them every 6 months or, you know, year for recall. A patient who, however, does have a history of peri-implant disease or periodontitis, you know, we'll see more frequently. So potentially every 3 to 4 months. And the red, of course, includes any type of intervention as needed. So we see the frequency of which is a little different. So the green line is on a daily basis, professional maintenance a little less frequently, and then of course intervention as needed. So this could be antibiotics, this could be surgical therapy, non-surgical therapy, and again, you see it much less because it's on a need basis, since we're enforcing hygiene and maintenance on a more routine level. So diabetes. So we know that diabetes and the periodontium are very closely related and almost have this bidirectional relationship all through systemic inflammation. Now in the US, 34% of adults who are 18 years or older and almost 50% of adults 65 years and older are at an increased risk for type 2 diabetes. And the amount of glycemic control is, again, what's important. So just because a patient has some form of diabetes doesn't mean that they're not a candidate for implants. It's really a patient who has uncontrolled diabetes. So our target profile is, of course, 6.5% or less, but a lot of times we find ourselves 7% or less. Patients who start to have a lack of compliance with their overall health become at greater risk for implant problems in the long term. So just like we kind of add systemic complications or conditions to our periodontal prognosis, we're going to do the same for implants. And I think as implants have been placed, we're just realizing that they're not necessarily a panacea for replacing missing teeth. It's not like the tooth comes out, you replace it with an implant, and we walk away. And so that's why we kind of keep coming back to they can't be placed and forgotten. So just like diabetes, this is a patient who, you know, even if you could get one side fixed so you can chew, that would be great. So interestingly, I did implants on the upper right, upper left areas, upper left, no problem. And these were all done at the same time. Upper right, this patient, just looking at his medical history, type 2 diabetes, porcine valve replacement, morbid obesity with a BMI over 50%, glaucoma, you know, a number of cardiovascular diseases. He's on 20 or more medications just because his control with this is so non-compliant. And this was 2 weeks post-op. He literally presented and I removed one of the implants with my finger. You know, could I attribute this to potentially some occlusal forces? He told me he was eating, maybe, but I really think, you know, to some degree, his overall health may have been contributing to this. We're able to successfully replace this with an implant, but even still, his just overall health, I don't think was good enough for us to be able to place as many implants as we initially did. So smoking cigarettes. So again, we know cigarette smoking is a known risk factor for periodontitis, but with peri-implant disease, it obviously will have greater crestal bone loss, but a lot of cross-sectional studies may not necessarily relate that to implant complications. With the growing rise of vaping or e-cigarette use in the United States, this also causes some inflammatory cytokines that cause or are associated with bone loss. What's interesting though, is that we now know that patients, even if they quit smoking, they never really return to the level of a non-smoker. So we used to think that over a 10 or 11-year period that these patients would kind of fully come back to a point of that of a non-smoker. And now we know that over time, their disease risk really only decreases by about 3% every year. So for as many years as you smoked, it really will only decrease by that much, by 3% every year thereafter. So never really returns to baseline. So it's controversial, which is kind of surprising, but of course it's still a complication of note. And then medication. So this is probably the most surprising to some of you, is that the medications that some patients are taking is actually contributing to some of the disease breakdown or implant failure. So SSRIs, so selective serotonin reuptake inhibitors. So serotonin is a natural osteoblast inhibitor, meaning that it inhibits wound healing cells or bone forming cells around implants. So what a reuptake inhibitor does is it inhibits the reuptake of an inhibitor. So essentially you have more inhibition of bone forming cells generally. And so that is the kind of the known theory, or that's what's been linked with a greater risk in implant failure. So again, this may be a conversation that you have with your patient. They're taking sertraline or Zoloft, which is the most prominent of these associated with implant failure. And at their initial appointment, you can just address that, as part of their consent form or as part of your discussion with them, that they may have a slightly greater risk for implant problems in the long term, and you'll just have to maintain them more closely. Proton pump inhibitors have been associated through calcium metabolism in the gut to a weaker degree, so about 4%, but even the evidence to supporting that isn't as profound as what's been found with SSRIs. NSAIDs, so sometimes even with joint surgery, NSAIDs may not be prescribed, and that's just because of how they affect bone metabolism, but again, to a weaker degree. Some patients who are on anti-resorptive medications or those who have osteoporosis or osteopenia, obviously, of course, while we get consults for these patients to minimize their risk for ONJ, we know that there's really no significant difference in implant success if they're taking a low dose and have no history of radiation. So any questions so far on patient-related risk factors before we move on to different site level ones? All right, so seeing none, and again, you're obviously welcome to use the chat here. We're just going to shift gears a little bit. So the hard and soft tissue architecture at the site of implant placement is critical to the long-term implant health. So the role of keratinized mucosa around the implants has gained recent interest and seems to offer a protective element to the soft tissue stability. However, the time to necessarily intervene and either thicken a patient's phenotype or increase the amount of attached tissue varies by study, but seems most appropriate when the patient experiences discomfort when brushing. So one of the common questions I ask patients when they have thinner tissue around their implants is, how's your brushing in that area? Is it uncomfortable to you? And the way I equate it is like looking at your hand. So the palm of your hand is thick, it's functional, and that's what I usually equate to that thick attached tissue around teeth or around implants. And the back of your hand is that mucosa, that oral mucosa that you have. And that can be a result of ridge atrophy over time, an implant that may have been placed a little too buccally and slowly lose some of that tissue support, a thin vestibule. So again, we're considering the total profile of the patient, but then at a site level as well. So almost double the amount of recession had been experienced and greater bone loss was observed in patients with a shallow vestibule. And we'll kind of circle back to some of these when we discuss the aesthetic challenges of patients. So this is a patient who reported that his lower denture wasn't stable. He had 2 teeth that were previously used as telescopes for abutments. Again, a not really contributory medical history between his joint replacement and other associated conditions. So upon initial evaluation of 22 and 27, again, they support as root-supported locator attachments for a mandibular overdenture, and they were deemed non-restorable due to recurrent caries. So even on this initial impression, I know on the facial aspect of both these teeth, there's a complete lack of attached keratinized tissue. And so that as part of treatment, we'll have to consider a free gingival graft or some type of soft tissue grafting to augment the lack of tissue thickness. So the implants were initially placed in a restoratively driven position, and at time of implant uncovery, we actually went ahead and proceeded with a free gingival graft. And again, the goal of which was to augment the amount of keratinized tissue present. So we repaired our recipient bed on the left. I did a bilateral harvest on the upper left and upper right. I like using a tissue punch around implant abutments. And again, that allows the soft tissue to adhere as close to the implant abutment as possible. And that can similarly be used for crown contours, but you see how closely that's adapted. And I always tell patients, don't look because you don't know what you're looking at. So what may appear to be infected or problematic, like we see here on the left, that's just revascularization of the tissue. So as the tissue, you'll see, you know, from 1 week to 2 weeks to 4 weeks, develops that nice pink tissue. So when you transplant a piece of tissue from the roof of the mouth around the implant, you'll see kind of that profile change. And this is about a month post-op healing. So this is favorable for a couple of reasons. One, of course, being implant maintenance. You know, again, brushing along hard, you know, attached tissue is more comfortable to the patient, but also from a prosthetic point, you know, he has mandibular overdenture that will be seated here. And instead of rubbing on the tissues, it'll now be properly seated on thick keratinized mucosa.
So this was a patient of mine that, again, very similar case. We did have, in fact, here we did have about 1 millimeter or 2 of keratinized tissue, but, and I don't have a pre or photo, I wish I did, but there was really like a big soft tissue concavity. And if you can see right here, this frenum attachment that was fairly high before we did the surgery, along with that soft tissue concavity. So when this was more of a concern from the prosthetic standpoint, because once they were planning the prosthesis, there was going to be a soft tissue defect where, and with that frenum attachment. So they were really worried that the patient was not going to be able to get in there and clean that area of the crown margins. So this was a two-way, like a twofold reasons for why we treated this, other than giving her increased keratinized tissue, but also really fattening that tissue up on that buccal side. So as you can see, we did the harvest from the same site, like the harvest was a single incision harvest. So we got a nice big graft from here and then push that on the buccal side. So most of this, at least 4 or 5 millimeters in that, under that flap is all soft tissue graft. And then we left some of it exposed so that it can get keratinized. So this was where the original margin of the flap was. And then this is what we gained. And then along with pushing the whole tissue slightly apically and the frenum. So it helped create that bulk of profile on that, the buccal surface, so that when the patient gets the final crowns, there's no dip in that, right in the cervical region. So that's sometimes also the other indication when you're doing implants. If you think like you're going to have a dip against something that the patient won't be able to maintain at home, then you might want to consider augmentation, whether it's soft tissue or hard tissue. It can be a combination of two if needed. And this is the patient that I had in the start. So again, you can clearly see all of this is mucosa. And then we did a free gingival graft. So this was at, if I remember correctly, I think this was a 3-week post-op. And you can see very faintly the margins of that free gingival graft. But again, it was very similarly done like Adam's case, except we only did 1 harvest because it was a smaller site. But it was placed right along the mucogingival junction, and then we got all this increase in the band of keratinized tissue. The other thing also this helps is, again, if you see here, you can almost see that grayish appearance of the implant from underneath. So which probably also meant that the bone plate there was pretty thin. But we looked at it radiographically and we evaluated the site. It didn't need bone augmentation at that point. So we just went ahead and did the soft tissue. So it also helps with that. And now the patient can maintain this better and clean this better. Some of the hard tissue deficiencies, like we were talking in the beginning, so we've spoken about soft tissue, you can also have hard tissue deficiencies. Now, a lot of time, like at least, like I'm not sure, again, if this is a common theme in India yet, but Here, for most of our patients, we've started to take CBCT. And so a lot of times you can know if the patient has a heart tissue defect, other than, of course, looking at it clinically, but you can also radiographically, in a 3-dimensional view, make sure that you have adequate bone before, and digitally plan your implant before you place them. So if you see that heart tissue concavity, and in a lot of these patients, if they do have that heart tissue defect, it's almost obvious clinically. Very rarely the CBCT gives you something you already didn't know, because you can see that dip. If you just feel for it, you take your finger and feel that area of the denture side, your finger will dip into that bone defect. So especially if you've had a traumatic extraction or extraction where the buccal plate was very thin to begin with, you are going to lose that. Even if you do ridge preservation, you still expect up to 40% of that bone remodeling. You can lose, I mean, you normally lose more of your horizontal bone than the vertical height, but you should expect that. So if you're going to do extractions for a patient with the hope that you want to place an implant there, you have to again consider ridge preservation, maybe grafting that site, or at least making sure if you have a thick buccal bone plate, if you're not going to graft that site, because that all also affects how the bone will remodel over long term, and then whether you'll have adequate bone for an implant. So I just want to show a case here. So this was a patient, he was relatively young. I think he was in the early 30s. He had an extraction, I think, a couple of years ago before he presented to us. Here you can see that the ridge looks maybe adequate, but right in this area, it like dipped down and there was like a pretty substantial defect. And again, you have to account for that. There's also probably a couple of millimeters of soft tissue thickness here. So when you really raise a flap here, you can see how thin that ridge really gets. So right here, if you took a probe, you probably measure only like 3 millimeters of crestal ridge. And as it goes further apically, there was this dip that I was talking about, it was a concavity. So obviously this wasn't, like we couldn't place an implant at the same time. So we decided we want to graft first, let it all heal, and then come back. So I can get a little bit into detail of the surgery. So this is just a collagen membrane that I first sutured on the lingual side. And then this is particulate bone graft. It's a mix of allograft and a xenograft. Right here, the holes that you see in bone, we did decortication. So made sure we got nice bleeding there so that the cells can repopulate that area. And then covered the whole graft site with the membrane. And you have, I believe I put a couple of tacks, actually maybe there might be 3. So 3 screws there to really secure that membrane. Again, not to get really detailed into the grafting part of it, but the key here is again, having that stability of the membrane and the graft if you really want to achieve a nice augmentation of bone. And that's just sutured right after. Some of these are non-resolvable, and the black purple ones are the resolvable sutures. This was at 2 weeks of healing. So you can see this nice little bump here that's been created. Now, again, when you graft a lot, you still expect that some of that graft will resolve. So you always overgraft so that you can come to a point where you want it to be. But as of now, the patient has an implant there, and he, I think, just recently got his prosthesis there. So it worked out. And also the good thing that helped us here was that he had really nice amount of that keratinized tissue. So that's always a plus when we're trying to do this hard tissue augmentation. This was another patient here. As you can very obviously see, there's a much, like this really deep buccal concavity, along with this high phenum attachment that's going right in the concavity. This was also a young patient that had a very traumatic tooth extraction. So they lost entire of that buccal plate at the time of extraction. So he really didn't have much going on. But he obviously, again, young, wanted an implant there. So we went ahead and did the same thing. Again, bone grafts underneath this and the membrane right over it. But this time, instead of using tacks, I use sutures to secure my membrane. And then that's at the time of implant placement. So you can see the augmentation here compared to what it was previously. And this was the patient now. Here we placed the implants, and then he recently got his crown. It's doing pretty well. It's just the same thing, showing you a different view. Right. Adam, you want to take over?
Yeah, beautiful work. So moving on a little bit different pace, what happens after we place the implant, and how can the prosthetic phase affect the work that we've done? So I always joke with patients, I do all the dirty work and the dentist gets all the credit, which is true. So, we're just like Anuja was describing, set the foundation for healthy and maintainable and hygienic outcomes in the long term. So with respect to cement, there's pretty wide variance in how this affects implant health. So again, with studies 0 to 81%, but generally speaking, excess dental cement has been found and obviously associated with implant disease in a majority of cases. Now, greater excess cement has been found at time of earlier delivery. So in cases where, for example, you may need to go in and uncover the implant, waiting at least a month or so before moving forward with any restorative element will help prevent the cement from creeping down into the implant, because it does take, from a wound healing standpoint, about 4 weeks for that epithelial seal to form around the implant. The number of pathogenic bacteria has been greater associated with permanent cements. So using a temporary cement like Tempon or Temerex is what's favorable. And again, it's not so much the cement that's holding the implant in, it's the height of the abutment. So placing an implant too shallow and then asking your restorative dentist to restore that with a cement retained prosthesis, just like a tooth that isn't long enough and may need crown lengthening, that's where you run into restorative issues as well. So the restoratively driven position is so important for a variety of reasons. So this is an example of peri-implantitis. This wasn't necessarily a cement-driven issue. However, from a radiographic standpoint, which you'll see in the neck image, there is the phenomenon of open contacts around implants. And this is something, again, that's newly being described. So implants have been placed for decades now, but a lot of the research is now being done. So this is the patient. They had an immediate implant placed in the upper right premolar area. I believe for, you would call that 1-4, maybe?
Yeah.
Here, 1-4. So again, around this implant, the osseous decision was made. Instead of going ahead and trying to regraft, we see that the circumferential defect is usually what's found around implants. So instead of having a graftable defect, something that's deep, something that's narrow, I ended up doing crown lengthening, and informed the patient that they would have to have the etiology removed, meaning the open contact between 1-3 and 1-4 would have to be closed as part of the overall treatment plan. And again, that's because we're addressing etiology. And had I just done surgery, if you go to the next image, you'll see that it doesn't create the most aesthetic outcome. We see the abutment, we see marginal recession on number 1-3. However, as part of treatment, this will set her up better to avoid problems in the long term. So some of the discussions now we're having with patients is we start to see these open contacts over time. And that's because the implant doesn't move in the jawbone, but everything else continues to move down and forward throughout life. And so again, just recontour the bone, apically positioned flap, natural papilla fill, but again, the abutment would have to be exchanged, and the adjacent crown can either be redone or the contact closed with number 1-4.
So as Adam already alluded to, was that this was this fractured crown here was one of the patients at UNE. They had the implants placed here, but one of the things he mentioned, so these implants had, there were two issues. One was the implants were placed really shallow, so there wasn't enough restorative space to begin with. So there was very limited room to have that ceramic and your metal and ceramic there to begin with. And in addition of that, the patient had bruxism. She was a chronic clencher and had nighttime bruxism. So what we wanted to talk about here was traumatic occlusion. I think a lot of times this aspect gets ignored in implant treatment planning. We look at all the other things, but we don't really think about, okay, patient's history as far as clenching or bruxism, are the night grinders. So that's something to ask the patient. If they don't know, you should always ask, okay, if they have a spouse, have they heard them grinding? Because that can really change implant outcomes. And again, this is also something that's being, in the more recent years, has been looked at more. the main reason here is, which we've already spoken about, that your implants don't have that PDL. Your PDL has that cushioning effect. It can take all the forces, but your implant doesn't have that. So when you put more forces on that implant than it was meant to take, it is going to, the only way the forces dissipate is in the bone. They don't go anywhere else because it doesn't have the shock absorbent properties. So you have to take patients' occlusion into considerations, especially if they have bruxism. You should consider putting a night guard. Now, the common issues with this is, other than the prosthesis fracture, is the implant fractures. We see patients, I've taken at least, like, in my very short career yet, like at least 5 implants that were fractured because of occlusal trauma, because it was too much occlusion. There was one of those patients had a really large crown on a very small implant. So there was like a cantilever sort of on that implant. So that is going to result in implant fractures. So especially if the other case that Adam showed, that where the patient wanted chewing on one side. So if you have a patient like that, oh, get me just one implant in there so I can chew on the side, you have to think about it that, okay, if he's not chewing on the other side, how much forces are going to be on that one implant that you put for him. So again, maybe you have to change the prosthesis, maybe convince the patient to get 2 implants, and then you can splint them, again, to expand that occlusal profile. So these are some important considerations. I had one picture here of the implant fracture where the issue with implant fractures is that you still might have adequate bone. It still might be osseointegrated, but there's nothing you can do. You can't put a prosthesis on this, so it has to come out. And taking out implants is honestly a very painful procedure, not so much as directly for the patient, but you have to take away so much bone to get a good osseointegrated implant out. It takes a lot of effort and it's not fun. But if you see right here, you can see that fracture line going all the way in that at least coronal third to middle third. And this was because of the occlusal loading. This patient had his crown replaced twice because the first one was loose and they did it again. And I think in those series of crown replacements, at some point it was torqued too hard and there was a fracture. But so again, you have to be mindful of that you did all the hard work of placing the implant there, but then if the occlusion is wrong, you can result in a fracture. So there are a lot of considerations when you're talking about implant occlusion, force direction, magnitude, as well as the type of bone quality. We haven't included cases here from like poor bone quality as such, but if you are in a site which has poor bone quality, which is normally your maxillary posterior regions, tends to be type 3, type 4 bone, then you want to change the type of implant you use. There are conical versus straight implants, and like the tapered implants do better in softer bones versus your straight implants are better for your more dense bone. So again, just considerations like that, along with having, I don't do my own crowns and prosthesis. So obviously having that conversation with your restorative dentist is very important, just to make sure that because if you say at the time of your implant surgery came across really soft bone, you want to make sure that your restorative dentist is aware of that. Even though you might have done a great placement, they have to be aware, okay, this is going to be a bone quality that might be softer versus the dense. So the considerations in the final occlusion. So just as this article, if you want to go read it, it has a really good description and a whole review of occlusion on implants. The next thing is implant placement. I guess you all should probably know the rules of implant placement, and this is really the key. The first thing you can do correctly from as far as the surgical step goes, making sure you place your implants correctly. You have that 1.5 millimeters between your implant and tooth. If there are 2 adjacent implants, you want to have that 3 millimeters. This is all based on research in the Tarnow papers, which that if your implants were placed too close together, you can have bone loss. So there's a reason why we do this. And then even your buccal bone, right? So your buccal bone and your buccal tissue should be at least 1.8 to 2 millimeters thick to be able to have a sound implant positions. Because if you do that step correctly, the subsequent steps can also follow correctly. If you place your implant too far buccal, there's not much your restorative dentist can help you with at that point. So just to show like an ideal implant placement, just a single implant placement on what would be 1, 2. So again, if you look at it, we respected at 1.5 on each side. This was a maxillary implant, so I chose to go with a tapered. And then on the buccal surface, that we have nice 2 millimeters of that tissue thickness. Same thing, just another, like I always tell my students, if you're going to be a recent dentist is going to just start placing implants. And if you want the experience, before you start feeling comfortable with it, go slow. Place your implants, take your first osteotomy guide pin x-ray, make sure you like the angulation, put your guide pin in, make sure you like where it is centered and all of that, and only then proceed with the subsequent osteotomy, because it's very hard to correct once you have the osteotomy wrong, once it's all towards your final drill. So make sure you correct it in your first drill. And then... Was there a question? Sorry. All right, so this was just another case where the implant was clearly placed too far buccal. It's very obvious here. This is a very common reason for implant removals. Now, in this particular patient, despite it being so far out, taking out the implant wasn't an option for 2 reasons. One, the patient was on bisphosphonates, and going through that kind of trauma, we were really worried about just causing necrosis. But the other reason was also she refused. She's like, I have spent too much time and money on this, and this is not coming out, so you have to do something for me. Now, these become really hard to treat, because if you can see, there's just all mucosa right there. Like there's not a whole lot you can do. So what we attempted was to use, so we did some osteoplasty as essentially the same thing like how you would do odontoplasty when you're doing soft tissue grafts, and then followed by using an allograft that we placed right there and then closed it up. We were not expecting full root coverage, which we didn't, or I guess implant coverage, but we still got a little bit. This was just 2 weeks out. My hope is once this tissue matures a little more, maybe do a second round of grafting. But the key was really just for her to be able to maintain this, because she just accumulated so much plaque on that surface. All right, I think so. This is the next part of Adam.
Yeah, so again, a lot of this isn't to scare you away from implant placement, surgery, or restoring implants. It's again to just better educate you on the challenges that we faced surgically, and how that can really, with that Swiss cheese model, set things up for poor outcomes in the long term if they're not managed initially, or the expectations aren't set for the patient. Sometimes no matter how good a surgery we do, there's just limitations in that respect. So even though we already described some patient and site level risk factors, when we place implants in the aesthetic zone, there are even more things we have to be concerned about and counterbalance as part of surgery. So thin buccal plate. The average buccal plate thickness is less than 1 millimeter thick a majority of the time. So we already know that as part of implant surgery that we're going to have to do some type of augmentation, either within the implant socket gap or do some type of bone grafting at the time of tooth extraction. Pre-existing bony defects, so there are certain dehiscences or bone shapes that may be less favorable. Again, the lack of bone support or the lack of blood supply is what causes most of these challenges intraoperatively. A buccally malpositioned implant is obviously more likely to develop hard and soft tissue deficiencies in the long term. And then a thin phenotype. So an easy assessment for that is to just run your probe through the facial sulcus of the tissues prior to tooth extraction. And if you realize that you can see the probe like here through, even just faintly through the tissues, that may be a consideration for soft tissue grafting as part of your implant surgery or the provisional phase, or even just letting the patient know that that may be needed in the long term will just help minimize certain challenges. So overall, you should expect about 0.5 millimeter of recession and about 20 to 30% risk for developing marginal recession over time. So, just accounting for this at time of surgery will limit any surprises down the road. So this is a protocol that I actually developed as part of my master's research, and it's called contour bone augmentation, contour bone grafting, and it's where you graft beyond the envelope of bone. So traditionally when we're placing immediate implants, and again for implants in the aesthetic zone, we need to account for some of these natural changes in healing. So we graft about 1 to 2 millimeters, as you can see, beyond the arch form. We also do a procedure called phenotype modification. So again, if we have a thin periodontal phenotype, as part of treatment, we may be considering the use of not only a bone graft, but some soft tissue graft, and that's to just increase the soft tissue element at time of implant surgery or wound healing. So just looking at this protocol, very similar to what Anuja already described for conventional implant placement, this is a phenotype-driven protocol in the aesthetic zone for implants that may be replaced at the same time. So the reason we do immediate implants is not only to save on surgical time, but we kind of capture as much native bone anatomy when we place these implants simultaneously. So we see that the implant is in a very restoratively driven position. It's on the palatal. It's not too far buccal. It has a good depth, meaning that it's not too deep and won't be hygienic to the patient. We see that over contour grafting done around 3 and 4. In this case, a connective tissue graft was also done. So I think extrapolating this to kind of real world practice, as great as this would be able to do on every patient, the finances and the likelihood of wanting to go through bone grafting and soft tissue grafting simultaneously at the time of tooth extraction and placing an implant, that's just a lot. So I think addressing bone first, and making sure that we have adequate bone thickness is more of an issue in patients who have a thicker phenotype or gum thickness. Whereas patients who have thinner tissues, we may be more inclined to just do the connective tissue graft and not focus as much on addressing the bone quality at time of, if it's thick enough to support it. This is actually provided by the ITI. So you should kind of get the feeling that not all patients should be promised immediate implants because there are many factors that affect your treatment plan. And one of the ways that is a nicely packaged tool is the ITI's assessment. And so we can look at it from a surgical standpoint as well as a prosthetic end. And it considers risk factors like their medical status, smoking habits, gingival display, smile line, the width of the edentulous ridge. And what's the absolute worst case if you can't place an immediate implant? You just ridge preserve the site and place the implant in 3 months. So not the end of the world, but this is again a great tool that I often use to just mentally assess all of these checkpoints, because it's very easy to just kind of push through things and not account for some of these discrepancies. So as part of the post-op evaluation period or the perioperative period, when we place an implant, immediate or not, there are several options to replace missing teeth. So this is my opinion. And so you can take it or leave it. So a removal dental prosthesis. So to me, this is not ideal immediately post-op, especially if you're considering any type bone augmentation at time of implant surgery. And this is because the lateral pressures of the tissue can be displaced from the prosthesis. So especially if there's any buccal flange or even on the lingual aspect, any lateral pressures can displace some of your graft material. And like Dr. Doshi already described, we're already anticipating about 30 to 50% of bone resorption as part of wound healing. And if you're going to have something that's already pushing on that area, we may lose that more quickly. So I'm personally not a fan of what we'd call a flipper here. And a lot of patients aren't either, just because the term flipper is not as friendly if you're not a dolphin. So a provisional. So provisional works for type 1 and 2 or immediate or early implant placement. It can even work for delayed implants. But again, it doesn't really offer an interim solution during the initial months of healing. So provisional is obviously great because it can help develop some of the soft tissue anatomy prior to having a final restoration. The only challenge is if the patient has a deep bite, if your experience with provisionals isn't as skilled, you can actually cause problems to the implant as it's healing. My preference always seems to be an Essex. I call them party teeth. They're great. You can even convert, if your dentist provides you a surgical guide, into the Essex immediately post-op. And it's an affordable option for patients, and it's not impinging on the tissues as it heals. So again, we need to consider some of these post-op because it can affect grafting outcomes. More specifically to the provisional and the final crown contours, there's been some more information recently. If something is a little bit more convex, it's obviously going to push the tissues. So sometimes we want more of a concavity, and that's going to allow more apical support in the soft tissue color to better develop. These guidelines somewhat change for delayed healing just because we can adjust those contours. But again, you see, you want them equal or most natural to a tooth. And the depth of the implant placement is important. If I don't place the implant deep enough, especially in the aesthetic zone, there's not enough running room to really build out this abutment to develop the crown contours that you really need to maintain the implant in the long term. So as part of wound healing, we see patients at 2 weeks and 6 weeks post-op, sometimes followed by a 8 or 12-week check, depending on the patient. The implant system may change that. So we use SLA actives, and the hydrophilicity of these implants allows you to check patients sooner for their final outcomes. But in any case, most of these infections occur within the first 2 months, which is why it's so important to see your patients frequently in the initial healing period. And so we see some marginal swelling immediately around the implant collar here, and 89% of patients who had these post-op infections within the first few weeks required some type of surgical intervention. So this was a relatively easy fix. Prior to the implant being loaded, we went ahead, debrided the defect. And when we're treating implants, it's not similar to teeth where we may be more aggressive in our instrumentation. Now we're finding today less is more. So, we had some initial bone loss 6 to 8 weeks after implant placement. We can already see kind of a marginal defect on the mesial. And again, implants, the pattern of bone loss is very similar to that left image there, where you have that circumferential, almost cupping defect. So no antibiotics, no glycine powders, no even chlorhexidine was used, really just a matter of using normal saline. Because again, what we had previously thought in throwing everything at the implant is probably the worst thing that we can do today. So less is more in terms of managing implant disease and implant failures. So, and this is 3 months afterward, we see bone regeneration to where we'd expect, nicely around the collar of the implant. The tissues are nice and healthy. They're not inflamed as they once were. So this is a good outcome that we can now restore and move forward with. And implant replacement. So anytime an implant fails, we obviously want to address why, but then we want to go back and potentially replace that with an implant. Well, before we do so, we need to understand that the success or the survival of which does decrease at every attempt. So typically first placement, we're looking in the high 90s. Second attempt is high 80s. Third attempt is you're in the 70%. So odds are still favorable to you, but it's just worth noting for the patient. I've attempted 3 implant replacements and it was successful, I guess, 3rd time's the charm. But again, who knows if they're going to have any complications or problems in the long term. So again, just having these conversations is what's so important. And, you can think of your own analogies. Like I learned something from Dr. Doshi today with the joint replacement, so, and I'll be stealing that. So it's just great because you can go ahead and talk to your patients. You don't, these, and when you do so ahead of time, they're not excuses. So it's all about education. Do you want to bring it home?
Okay. So again, as we already stated, that the best way to manage complications is to prevent them. So know your risk factors, know what you're set up for, everything, not just medical history, but to know the sites that you're dealing with, the patient's bone quality, occlusion, like habits, everything when you are doing. So for a successful outcome, you need successful planning and then the execution of that planning. So again, like it's not uncommon that we also see like some of our students who graduated and they just want to start placing implants, but we want to make sure that before they do that, and I keep telling them that go ahead and place implants, do that, but make sure you understand the science, make sure you understand the biology and respect that when you're going to start treating with patients with implants. A lot of your implant patients will come to you thinking that, okay, I just want this because implants are forever. because that's what the belief is, or that's what was told, in fact, for really long. But you also have to take into account that a lot of the implant studies that we look at, 10-year follow-up and 10-year success rates or 15 years, were also patients who were potentially in a much older population. Now we are placing implants in also younger populations. If I'm placing an implant in a 35-year-old patient, I have to think of this implant lasting for 50 years. So, and we don't have that kind of data to even know if this will last 50 years. So again, like having conversations with patient and making sure that you've checked all your boxes can at least give us long-term implant outcomes. Maybe not forever, but we can aim for long-term. Always, always, always place your implants in restoratively driven positions. This is something I drill into my students' heads as well, that don't place the implant where the bone is. Because when you, like so many times, it's very tempting to place the implant. Oh, I have all this bone on this side, so I should just place it there, and not really placing where the restoration is going to be. So again, you have to plan backwards. Where do you think the final CEJ is going to be? Where do you think that if you're doing a screw retain crown, where will my screw channel access be? So again, place them where the restoration is going to go, and don't let the restoration follow the implant. So plan backwards. And as we've already said this a million times today, make sure your patient understands the importance of oral hygiene. Start doing that work ahead of time before you even place the implant, to make sure they understand that if they have plaque, if they show to their routine visits with plaque and calculus, you are saying, no, this needs to change. You need to first improve your oral hygiene for me, and then we'll get to the implants. And making sure that once they get the implants there, they should see you routinely. What we do here, and probably Adam does that too, is that we, once the implants are placed, at least for the first year or maybe even 2 years, we try to alternate between the periodontist versus the general dentist, so that they don't have to see me every 3 months, but at least we alternate it. And then after that, if the patient is stable, they can choose where they want to see their recalls. But especially in that first couple of years is really crucial, that you see them more frequently. And as periodontists, we are the ones that understand bone, the tissue around it the most. So I guess it's important we see them for the first year. And something we've already said today, that the importance of tissue. So there's more research on that now. So making sure, again, making sure you have adequate keratinized mucosa, and tissue thickness is also really becoming the key in your long-term implant success. Do you want to add anything?
No, I think those were all great takeaways, and it's just important to educate patients as part of their initial exam, so you don't create excuses in the long term as to why they develop problems. Again, there are so many different risk factors today that we weren't aware of 10, 20 years ago, or even the last few years. I read an article a couple months ago about this open contact phenomenon, and anecdotally, people would hear of, the downward and forward growth of the mandible or the maxilla over time, and now there's a study to justify that. So I think we shouldn't be so quick to necessarily take out teeth. I went to a lecture recently, and a prominent periodontist described how there's almost the shift back to saving teeth. There was this period of tooth is problem, take it out, replace it with an implant. But now, as you see, there are so many different issues that can affect implant placement or implant healing, implant prosthetics. So it's just important to really consider, from the beginning of how this can work and what can be done to counteract any problems we may face. And there are a couple questions, or I don't know if, do you want me to work
Yeah,
with
go ahead.
Answer? Yeah. So Dr. Doshi, a question for you. What can be done to prevent the bone resorption around the implants?
So again, the initial remodeling of that up to 0.2 millimeters of remodeling is inevitable. That remodeling is expected, and there's not much. I mean, there's literature on where you place the crest, the implant shoulder, that can change. So depending on whether it's placed subcrestally versus supracrestally, can change how much bone loss you can have. But other than that factor, the initial remodeling, there's not much you can do about it. But the real key in terms of prevention, so at least for some of my patients, depending on say if I had a patient who had history of periodontitis and is now maintained and controlled, but we are now placing implants for them. In those patients, even if I have good primary stability, I don't put a healing abutment right away. I put a cover screw on, close up the tissue, let the patient heal, and let that implant osseointegrate before I get in there and put a healing abutment. Now, again, I don't have data to say that this always works, but it makes me sleep better because since the patient was a previous periodontitis patient, they still will have that pathogenic flora. So during that initial healing time, so when we have osseointegration, there is a critical period where at 3 to 4 weeks, we have, it dips down, your primary stability dips down. And then as you are starting to achieve your secondary stability, between those two stability time points, there's a dip. So if at that 3 to 4 week period, which is really when the dip happens, if you have all this environmental factors acting on it, you could have a more immediate bone loss outcome. So those are my kind of patients where I try to be more careful with, and I will not put a healing abutment, let them heal, and then bring them back 6 weeks to 8 weeks later once my implant is osseointegrated, and then put the healing abutment. So that's something I do to help with that initial bone resorption. The other is bone quality. If you have poor bone quality, you are in your maxillary posterior region, let that implant osseointegrate. Don't try to rush and put a immediate load directly on it, especially like even as I'm learning through this process, I try to make sure if I'm in softer bone quality, I like to, again, let my implant osseointegrate, really heal up before I start loading or even put a healing abutment on it. And I've seen, at least in my experience, that helps. And I don't see as much crestal resorption compared to when I put healing abutment directly at the time of implant placement. So just some considerations. I don't know if Adam has more to add to that.
No, I think both were good points. To speak to the second question, though, about implant placement, either crestal or subcrestal, I think it depends on the approach. I generally place most of my implants equicrestal, especially if it's a delayed implant. For immediate loading, or not immediate loading, but immediate placement, I tend to be equi or subcrestal. Again, that's just with the buccal plate, or if there's a palatal defect, you want to be beneath the collar of bone there, and that's just to allow for proper bone fill into that space. So generally for an immediate, I'm equi to a little bit subcrestal, and I'm always equicrestal for traditional implant placement.
Also, there is evidence that if you place your implants too far subcrestal, you're going to get more bone resorption in the initial remodeling period versus placing it equicrestal or even placing it a little bit supracrestal. That's because of the whole micro gap, where your micro gap is going to be between your healing abutment and your implant. So if you should ideally avoid placing implants too far subcrestal. Sometimes we have to do that to create more restorative space. Like we've discussed before, you don't want to place implants too shallow if you don't have the restorative space. But in those patients, again, make sure you do an alveoloplasty, like flatten the bone out and then place the implant equicrestal instead of just placing your implant subcrestal. To prevent that micro gap from being subcrestal. And that, again, changes how your bone remodels.
Great. Fantastic presentation. And I think it was a lovely tandem effort, to go in. It's not easy doing tandem presentations, and especially the way you handled all of it and spoke about a wide array of topics. This is a huge topic. I think, one can go on for the whole day because you just can't finish it all in an hour and a half, which is unfair to the topic. But you kind of touched the key points very well. I just had one question: is what's your take on, three-dimensional matrices versus a free gingival graft for especially keratinized mucosa? What's your experience, either of you, on it? Have you used it, and how does it work? Does it work for you?
Do you mean like allografts, like
like mucografts, maybe a 3D collagen matrice, or dermal matrices, which are used for increasing the width of keratinized mucosa, especially? So,
in my at least personal experience, mucograft specifically is the one I've used, and now there's the FibroGuide from Geislick. Those at least in my experience, have worked better if I'm looking for soft tissue augmentation in terms of just thickening up the tissue. If I just want to do that and I'm not really trying to gain more keratinized tissue or really get that nice band of keratinized tissue, then they work better. But if I want nice keratinized tissue and like the thickness is not so much the concern, then I still prefer to go. I mean, in general, like regional grafts are still gold standard. So I will always try to convince the patient to get a regional graft first. If they absolutely deny it, that they don't want their palate or they don't want a wound on the palate, that's when I go to the allograft. Again, depending on where the goal is. If I'm looking for more soft tissue augmentation in a buccal lingual fashion, then I don't mind using the allografts. But if it's really to gain that keratinized tissue, then I prefer doing a regional graft. But that's my experience.
Okay. Dr. Adam, anything that you would like to add on this?
Very similar. Free gingival grafts are really my workhorse. I still like to use autogenous if I can do a connective tissue graft around an implant if I'm trying to, adapt some of the marginal recession or gain some more coverage over an abutment. But again, not all patients are fans of a palatal harvest. And I think FiberGuide in particular has been a really wonderful addition to the Geisslich profile of materials, and especially around immediate implants, I've liked using FiberGuide.
Okay. Oh, that's great. Also, I forgot to mention one very important point that you stressed on is, it's not because we're periodontists that we say this, but it's always better to try and maintain the teeth that you can with health and treat them when they have periodontitis than, opting for something which looks very easy at that point of time is getting it out and putting an implant in. But believe me, nothing lasts like teeth do. Implants are surely not going to replace that. So that's a point that I wish everybody takes back home also from this presentation, that, don't make implants your first go-to option. Try and save the teeth that we've got gifted with.
Yeah,
and
100%.
Even like the posterior maxilla where you have sinus involvement, I mean, it can really become expensive and timely to replace those teeth with implants. So absolutely, maintain, the teeth that you have.
Yeah. Preserve what you have and then replace. Yeah. So I think we're good with this. I don't see any more questions in the chat box. And thank you very much. It was a pleasure having the two of you. I'll hand it over now to the organizers to take this forward from here. Thank you so much.
I did want to say hi to Nilofer ma'am again, because she played a huge role when I was applying for residency. I used to bug her a lot. So hi.
Nice to see you, Anuja, like this.
Nice to see you.
Wish you success more in your future.
You so much. Thank you.
Thank you so much, Anuja ma'am and Adam sir. It was indeed one of the fun-filled roller coaster of implant-related complications and its management as well. It was a wonderful talk by both of you. Thank you so much for taking the time from your busy schedule. We have with us Dr. Nymphia Pandit ma'am, the President of Indian Society of Pedontology. Ma'am, thank you so much for gracing this occasion with your presence. I would request you to speak a few words about this session.
Yeah, sure.
Yes,
good evening, everyone, and good morning to our speakers. I'm so sorry that at that time the internet went off, and although this has been such a good thing that we are interacting on this platform, but this is one of the problems that we are facing. We had last year also a lot of foreign speakers and some very experts in their field at the ISP platform, and we were really benefited by them. First of all, I would like to say that Dr. D.G. Paul is one of our pioneers in the periodontics, and Mumbai study group has been one of the most active groups in the Indian Society of Periodontology, and this is no wonder that they are roping in the best of the clinicians all around the world and getting the information to all of the members. And this is only one thing that has happened good in the COVID times. Otherwise, everything else was really irritating for everyone. Everybody has been roped in and all that. But I would like to say this was really a very nice presentation, and both of you in a very short time did a great justice to the things. And as periodontists, we are always thinking about maintaining, and this applies to implants also, and maintenance, like we went from those to having this maintenance after every phase, because we are very worried about what is happening. What we are doing, within a few days, the patient falls back into his oral habits, and we land up with the same thing what we started with. So this is one of the most important things that I would like to emphasize at this point of time, and you have also been emphasizing that. And there was some very brilliant, nicely planned cases and very nicely done the complications handled, the way you have handled the complications, whatever has happened. And as you said, that the best way to handle complications is to prevent them and to place the implants where they should be, rather where you see the bone and just place the implants. And it was really nice being here, and I'm sorry that the internet connection went off exactly at the time when I had to speak. Congratulations to the speakers, and congratulations to the Mumbai study group, which has been really very active. As such also, and in these COVID times has created this atmosphere of study among our members and everyone at ISP. Thank you so much, and wish you all the best.
Thank you so much, ma'am, for being always so inspirational and encouraging to all of us. Thank you so much, ma'am. We also have with us today Dr. Amit Benjamin, sir, Professor and Head of Department of Periodontology from YMT Dental College. I thank you, sir, for gracing this occasion. Thank you so much, Amit Benjamin, sir.
Thank you for having me here. It was a pleasure.
Thank you so much, sir. I would now request Dr. Ashwini Padhe, ma'am, to announce the winners of the scientific paper presentation, which was held on 31st of July at the 7th ISPPG convention.
Hi, give me a minute, please. Yeah. So, okay, the winner for the best paper in clinical research category is Dr. Deepika Masurkar from Sharad Pawar Dental College and Hospital, Wardha. Then the winner for the best paper in the case report series category is Dr. A. Vinu Sarangesh from CSI College of Dental Science and Research, Madurai. And the winner of the best paper in basic research category, there are two, I think, Dr. Kirti Umashankar from Sri Rajiv Gandhi Dental College and Hospital, Bengaluru, Dr. Vaibhavi Nandgaonkar from Government Dental College and Hospital, Mumbai, and Dr. Lynette, our very own Dr. Lynette Fernandez from Government Dental College and Hospital, Mumbai. So heartiest congratulations to each and every one of you, and it's great, and all the best ahead for much more presentations. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. We had also organized a video contest on the occasion of Oral Hygiene Day. I would like to request Dr. Rajesh Gaikwad, sir, to announce the winners of this video contest.
Sir, you are not audible, sir. Sir, you are on mute.
Yeah. Thanks, Vaibhavi. On the occasion of Oral Hygiene Day, Department of Periodontology, Government Dental College and Hospital, Mumbai, along with ISP MHG, organized a video contest. The theme for the video contest was Dental Myth Debunked. We received over 17 entries for the same from the different parts of India, which displayed the creative minds of the budding dentists of the India. So the first prize winner is Dr. Shalini Thangvelu, consultant periodontist from Tamil Nadu. Then second prize again is shared by Dr. Apurva Dashputra, postgraduate student from Government Dental College and Hospital, Nagpur, and Dr. Sanika Chaudhary, final year undergraduate student from MGV KBH Dental College and Hospital, Nashik. The third prize again is shared by Dr. Mihika Shinde, final year undergraduate student from MGV KBH Dental College and Hospital, Nashik. And Ramakant Kadam, a dental hygienist from Government Dental College and Hospital, Mumbai. Then the consolation winners for this video contest, again, Dr. Prajakta Sable, postgraduate from Department of Orthodontics, Government Dental College, Mumbai, and Dr. Shubhangi Lokhande, practicing prosthodontist from Pune. And I would like to thanks Dr. Ashish Kumar, editor of GIST, and Dr. Sujata for judging this contest. Thank you very much. Vaibhavi.
Thank you so much, sir. I would like to now extend the certificate of appreciation to our 8 speakers of today's session. Dr. Adam Salz, sir, please accept the certificate of appreciation. Thank you so much, sir.
Thank you so much.
Thank you. I would now like to extend the certificate of appreciation to Dr. Anuja Doshi, ma'am. Thank you so much, ma'am, for collaborating with us, and I hope more future collaborations also. Thank you,
For
ma'am.
sure. Thank you so much for having me. It's been such a pleasure to talk to GDC again. And hopefully when things get better, I can't wait to come back. It's been really long since I visited GDC. My parents still live in Mumbai. So hopefully next time I'm there, I'll try to come visit.
Yes, ma'am, sure.
And thank you so much for having me. Thank you.
I would now like to extend the certificate of appreciation to our moderator, Dr. Ashwini Padhe, ma'am.
Thank you so much. It was an
Thank you,
absolute
ma'am,
pleasure.
for
Thank you.
accepting our invitation and being there.
Thank
to
you.
moderate
Thank you
this.
so much.
Thank you, ma'am. I would now request Dr. Rajesh Gaikwad, sir, to give vote of thanks.
Now coming to the end of the session, it was a great lecture delivered by Anuja and Adam. Basically, they are quite young compared to usually most of the speakers, but they have delivered this lecture on this implants. Usually, excellently they have presented. They have shown the how to manage complications, how to manage failures, and that is the most important part in the implant therapy. So again, thanks Anuja and Dr. Adam on behalf of ISPMAG and Government Dental College and Hospital, Mumbai. Thank you very much.
Thank you so much.
It gives me, it gives me great pleasure, privilege to honor and propose the vote of thanks again. Let's all thank the Almighty for abundant blessings in conducting today's proceedings. My very special thanks to Dr. Paul sir for being a pillar of strength in organizing this event. I would also like to express my deep gratitude to all the esteemed delegates of 7th ISPMAG convention for their contribution to make this event a great success. My heartfelt thanks for continuous encouragement by Dr. Nimthya Pandit Madam, President, Indian Society of Periodontology, and Dr. H.S. Grover, Secretary ISPHO, for continuous support. I would also like to thank my Dean, Dr. Dimple Padave, for her constant support and encouragement. Last but not the least, I would like to thank my all teaching staff of the Department of Periodontology, my postgraduates, especially Vaibhavi, Lynette, Priyanka, Namrata, Veena, and Amruta. So all my postgraduates, Shrutika, Nupur, and Sonal also. Then special thanks to Mr. Ashish for excellent flyers and in help in promotion of this event. I extend my gratitude to the moderator today, my colleague. We were colleague during our post-graduation, Dr. Ashwini Padde, for agreeing a part of this today's event. Actually, we have handed over, she had announced the best paper prizes today, and just wanted to let you know all that she was the winner for continuously for 2 years for the in the best paper in ISP. So again, some little bit memories. So
Thanks,
then
Rajesh.
coming. So at the end of the session, I would again thank Dr. Anuja and Adam for excellently delivering this lecture. Again, thankful to all the staff who have joined, Poonam Rai, then Dr. Amit, for gracing the occasion. Thank you very much. Good night.
Thank you. Thank you so
Thank
much.
you.
Thank you.
Thank
Good
you.
night.
Bye-bye. Bye. Thank you. Bye-bye.